So good afternoon, everyone, and welcome to the 88th session of e-NISCHIT, the National Initiative to Strengthen Collaboration between HIV/TB through e-learning. And today we have our states from Tamil Nadu and Andhra Pradesh and all the 7 northeastern states, and I welcome all of them. I am Dr. Upasna Agarwal. I work at the National Institute of TB and Respiratory Diseases and will be moderating the session today. Then on my left, I have Dr. Anuradha from Share India, who provides a lot of technical logistic support, if there is something like that. Today's expert is Dr. Alpana Raizada. She is a professor in medicine at the University College of Medical Sciences, and she is also the nodal officer of ART in that hospital. It's just for the people who are here, I would like to tell you that it is a very big public sector hospital, the GTB hospital in Delhi, and they have a huge ART clinic, and we are indeed fortunate to have her. Welcome, madam, to the show.
Thank you so much, ma'am.
It's actually a show, you know. And we also would like to welcome all our folks who have joined us from different parts of the country, and I would welcome Dr. Dharmapal from NRI AP. Dr. Dharmapal, can we hear a hello from you? That could also be a mic check for you. Can I please request now Dr. Dharmapal, the Senior Medical Officer from NRI AP ART Center, to present the case. I can also see that his Incharge is also sitting within. Welcome, sir, to the platform. And thank you so much for always sharing such interesting cases with us.
Yes, madam. This is Dr. Dharmapal, SMO from NRI ART Center. And the ART number of patient is also mentioned 1989, age is 37 years, gender male, weight 45 kg. The patient had enlargement of cervical, axial, lymph nodes, suggesting of PT or lymphoma, reactive of HIV1, and kept on TLD. Later diagnosed as a PT case bar lymphoma. Date of ART registration is 2/11/2021. Date of TB confirmation is 28/10/2021. Date of ART initiation 11/11/2021. Date of ATT initiation 1/11/2001. Type of TB detected is pulmonary, even though it looks like extrapulmonary TB, and the chest X-ray shows there are TB opacities and other things are there. So after having a discussion with the HOD of the radiology department and from NRI and also at Guntur, they also diagnosed as pulmonary tuberculosis. And the date of IPT completion patient IPT not done because this came freshly to us. Other details, example, a 37-year-old male was prescribed, presented to the ART center with complaints of cough, fever, breathlessness, weight loss associated with loss of appetite, night sweat, easily fatigability, and breathlessness, exertion from 1 month. He had personal habits of consuming a lot bouts of alcohol and smoking the last 20 years. Physical examination, both sides, cervical lymph nodes are enlarged, matted, and non-tender. Oropharyngeal region normal, and tonsils are also not enlarged. Both sides of the inguinal lymph nodes are enlarged. Hepatosplenomegaly is also present, and ENT examination, the ears are normal. No abnormal thing is found. FNOC of lymph node was done. Cytology for Jagan stain, including CB0 was done. Finally, on investigation CECT, MRI, neck X-ray, chest confirms PTTB. Then also with similar complaint symptoms of masquerading as lymphoma. After investigation, he was positive, suggesting of PTB. 4 FDC3 pills per day as per weight 45 kg and he was initiated on ART since 11/11/2021 at TLD. As for the CECT chest and abdomen, the hepatosplenomegaly, multiple enlarged cervical, mediastinal, mesenteric, and retroperitoneal lymph nodes with central necrosis. Investigations for above case is given below. Details reporting submitted, staying, scanning and biopsies also, etc. CD4 count of ART on ART initiation done at our NRI center is 498. And the CD last 3 patients died before that only. And date is 1/10/2001. And serum creatinine is 0.9 milligrams dilution, bilirubin 0.9, and urea 23.54 milligrams, and hemoglobin is 11.1 grams per dilution. Rapid HCV test is non-reactive, rapid HbS test negative, and PT is 15.4, INR 1.25, albumin 2.5, serum lactate deazolinase LDH a little above 300 units per lymph node. And biopsy reports suggest on 11120 that was done, and the smear studies show lymphoid series of cells admixed with few epithelioid cells and stromal fragments against hemorrhagic background. And the features suggest of granulomatous lymphadenitis. Ultrasound on 28-10-2021 we have done, and neck vessels for multiple lymph nodes and in bilateral cervical region at levels 16 to 3, 4. And IMP is bilateral cervical shows 5-10-201. Hepatosplenomegaly, multiple enlarged cervical, mediastinal, mesenteric, and retroperitoneal lymph nodes with central necrosis. The diffuse small tree in bud nodular opacity in bilateral lung parenchyma, possibilities including tuberculosis is more likely, and lymphoma less likely. And the chest P X-ray on 6/11/201. Findings are suggestive of pulmonary tuberculosis. It was also confirmed by the HOD, Dr. Alpana of Radio Diagnosis, Professor HOD, and he suggested in the case of clear-cut case of tuberculosis only. ERT regimen is TLD, and ATT regimen is 99 SCAT1, and the CPT is yes, and other medicines tablet Brandon 40 milligrams and omega D 20 milligrams was given. The issues for discussion is can 99.4 of these sufficient in this patient, suggest the treatment if in this patient initially if anything, differential diagnosis of lymphoma to rule out. And once again, I may be thankful to you, madam, because the last time we previously, well, you have shown us one beautiful case of the abdomen of this one that the gynecology professor told on the day. While suggesting that one, don't jump off away. And before that one, he wants to do that endometriosis for surgery hysterectomy. But after seeing the opening the abdomen, he found it should be that suggestion and the beautiful case which you have shown to us made me to think once again thrice like that. So that's why after careful investigation we found that is a case of tuberculosis but not lymphoma. We ruled out lymphoma. And the another thing is the posterior cervical supraclavicular nodes are also matted and not tender. That also we examined, and we have examined also to rule out this pediculosis also, because sometimes pediculosis itself is causing enlargement of the bilateral lymph nodes. That was also ruled out. So differential diagnosis also we have ruled out, and non-artificial lymphoma also ruled out. And I had a discussion with the cancer specialist of American Cancer Hospital here in our ground, and he also suggested it is not a case of lymphoma. So finally, we concluded this is only a case of lymphoma, and our nodal officer, who is an examiner for MD also, general medicine, and is a good teacher, famous in South India. He also confirmed that it is a case of tuberculosis only. And I am very much thankful to my teachers bow down to their feet, which is not bones and muscles of their feet. That is knowledge and action. So I am once again thankful to you, madam. We have learned so many things from you during these classes, and I always say I have learned something because my age is a little less, means I want to learn more, but unfortunately I am not like that. So I am once again thankful to my nodal officer, always making me any case, any different case is also discussing and making me to learn. For that, and all these people who are attended, and once Anuragaji and madam. So once again, I am very thankful to them, all of you. Thank you, madam.
Thank you very much, Dr. Dharmapal. This is indeed a very, very interesting case. And before I go ahead, can I please convey my regards to our director, sir, Dr. R.K. Diwan, who has joined our session today. And he is a leader in thoracic surgery. And I hope all of you remember the excellent talk we had on thoracic cavity chest wall abscess, which was a rare thing. Sir, before you get busy with your other meeting, can you say 1 or 2 words for our encouragement?
And thank you, Dr. Upasna, and thanks all the senior people who are working in the field of HIV as well as tuberculosis. And I just heard that the case presented by Dr. Dharmapal with so much interest. It's an interesting case. I'm sure the further discussion that it generates will be equally more illuminating. And ART data, as I just mentioned, that when I review the ART data in my institute, it is so heartening that so many people have been getting therapy and they have been living much longer lives than they used to live. As all of us know that in Africa, I was seeing one of the statistics, but this is one of the few diseases in which the mortality has steeply come down. A very heartening thing that those workers whoever is involved in this kind of work and is making these people live almost a normal life. And it's a very important aspect, as all of us know, of WHO area also, in which infectious of diseases as well as in national programs. So it's a very important area, and being a tuberculosis institute, we are very intimately involved with it. We see so many complications which are related to it. And as Dr. Upasna had been lobbying, advocacy, etc. Now, at least from the very beginning, earlier, in an earlier era, surgeons were afraid to touch cases of HIV positive. But we were never afraid. We said with universal precautions, every case of HIV, whatever treatment, intervention, or procedure that he or she needs should be given immediately. There should be no restriction or hesitation. That's how we can treat our cases very well. I will continue to join and keep on listening to the interesting generation.
Thank you, sir.
Thank you, sir. Thank you.
So this is just for the house. It is a thing of several years ago, but it is still stuck in my head. Dr. Diwan, when he was still a senior thoracic consultant and not the director, he one day came to me and said, I have operated an HIV positive person. And after I congratulated him, I just turned back and there were tears in my eyes, because there is nobody who wants to touch this group of people. And it is my salute to people who do not fear for their health, and yet they go ahead and provide help to people. So while you're thinking, if you want to ask something in detail, I would just summarize the case. It's a fairly straightforward case as far as clinical findings are concerned. It is not a straightforward case to diagnose or manage. But as far as recitation and just enumerating the findings is concerned, it is a relatively easy case. It is a 37-year-old person living with HIV. He is diagnosed with TB on 28th October last year. Promptly, ATT is started on 1st November last year. Patient is registered with ART center. Most probably somebody who was diagnosed with TB first and HIV later. And there also he was registered very promptly, and he could get the benefit of ART, which was TLE at that time and not TLD as it is now. TLE at that time, and it was started within 10 days, about 10 to 12 days of starting of ATT, a very prompt response in a case who had such disseminated TB. One point of interest in this case was that despite the fact that this person had pulmonary TB as well as disseminated tubercular lymphadenopathy in probably most of the groups of lymph node, like both cervical, inguinal, axillary, abdominal, mediastinal, he had such extensive lymphadenopathy, considering that the CD4 was very good. CD4 was 498, nearly touching 500. So the reason for thinking of a differential diagnosis becomes even more. It makes out the case that we should even think more that why should a person who is presenting with disseminated lymphadenopathy and a pulmonary lesion have such a good CD4 count? Are we missing a diagnosis? As we know, in HIV, two diagnoses can coexist. It is not like the traditional training that we had in medicine when we were PG students, that one disease you should be able to explain everything with one disease. Like our professor said, if you're diagnosing TB, the diagnosis should be such that TB should fit in the lung also and the extrapulmonary also, or everything should be explainable by diabetes only. But HIV medicine is totally diverse. You can have 1, 2, 3, 4, 5, n number of things happening together. They can be dementia, they can be a toxoplasmosis, they can be a PCP, they can be any number of malignancies, they can be cervical cancer in women. They can all coexist in the same patient. So finding one does not give you a sense of achievement. Okay, yes, I have saved the patient. So we actually have to find all. And I can understand why they must have gone on and done so many investigations in this patient, even though the patient was CBNAT positive. But one has to remember that very often in our practice, even in non-HIV people, we have seen that lymphoma and TB can coexist. Many times it has happened in our practice that somebody has come with two matted lymph nodes of the cervical lymph node, and somebody has said AFB positive. The patient has been started on ATT correctly. AFB positive is okay, but because we did not do a biopsy and we did not suspect a lymphoma, later the stage of lymphoma increased and actually the person had both. He had TB also and he had lymphoma also. So I really congratulate you for extensively like investigating this case, and the things that were in favor of TB were there. One was having CBNAT positive. Second was having a pulmonary and extrapulmonary involvement both. And the pulmonary involvement was not like some mediastinal mass. It was something that was seen in the parenchyma, a parenchymal pulmonary lesion. Third on CT scan was central necrosis. Usually central necrosis is not seen in non-tubercular lymph nodes on the CT scan. Third would have been good if we had a size of more than 1.5, having a group of lymph nodes, some matting, and central necrosis is actually the pathognomic signs on radiology for tubercular lymphadenopathy. And the fourth thing that was excellent, I would say, was that they got a lymph node biopsy done. All this can be just impressions which can turn out wrong in the end. But once you get a biopsy done, and please understand, not a fine needle aspiration, a full biopsy. The report of a full biopsy is very, very important to differentiate between TB and some other disease, because in a FNA, you only take a small aspirate. But when you do a lymph node biopsy, you get to see the whole architecture of the lymph node. And to diagnose lymphoma, especially early stages or different, like those rare ones which are seen in HIV, you actually need to see the entire architecture of the lymph node, and hence a lymph node biopsy is critical. So I congratulate you people for this wonderful case presentation. And with these thoughts, if there is nothing that the house would like to say, can we go ahead with the presentation of the day? Yeah, any hands, any clarifications? I think this is an excellent learning case, I would say.
Dr. Upasna, if I'm permitted again to make a query, although Dr. Anuradha has been really helpful in sorting out.
Absolutely, ma'am. You have every right to ask the presenter a question.
I am still not convinced whether it was actually a biopsy as stated, or if it was a FNAC, because the reports which were actually attached to the case showed an FNA report. So if Dr. Dharmapal and his team could clarify if this was a biopsy or a FNA report.
Only biopsy report, madam. They were done.
It was an excisional biopsy.
Yes, madam.
Okay, thank you.
Upasna was done in beginning at All India Institute, and but we were just we have got some doubt about.
We confirmed with the biopsy.
And another query again, which I received 2 different answers to it. That's the reason. Was the patient ART naive before coming to the center, or was taking it from a private practitioner, either ATT or ART?
He has taken ATT and ART also, madam. First of all, he has taken ATT. The private practice is an alcoholic, not has taken the AK-40, and some days he has taken stopped his regular and not taking because of economic problems. And once again, he is getting a weakness, and so he went to another doctor. Then he confirmed as HIV. He has not told anybody except himself only. But when he was in the bedroom stage, his nephew has taken him to All India Institute. There they diagnosed him once again. This one positive, HIV positive also. They referred the case back to NRI once again. So because HIV positive, they are not giving the treatment there, so they referred to us. Then only we have one state working. So what he felt is, I told CEC itself must be do. So that fellow thinks that government medical college Guntur is nearby us. So he has taken the patient to that center. There one of the surgeons is known to him. So they have done the biopsy, and CBNAT also we referred the case already. So they after seeing the patient name under Dr. Manasi, who is there, she referred the same once again, and she asked him go back to NRI only because your diagnosis is correct. What they have done. Their radio diagnosis professor Guntur also told this is not a case of And here our
Yeah, so thank you, Dr. Dharmapal. As I understand, he has taken some amount of ART and ATT from a private practitioner sometime back. Is that right? So actually, okay, so that slightly brings a different aspect to it. Possibly it was a flare-up due to iris if he had taken some ART on the background of partially treated or untreated TB. And that might be the reason that he has a good CD4 and he has such extensive involvement. But but considering the fact that it is still TB lymphadenopathy, can I now request Dr. Alpana Raizada to kindly share the screen and give us the presentation, which we have been waiting for.
A very warm good afternoon to everyone. I thank Dr. Devan for encouraging this session with his presence. And I'm delighted to be again part of this session, and many congratulations to the center, who I see very frequently as contributing very good cases to this platform. So this shows their zeal and will to keep learning and to keep sharing their good cases with us, which is extremely important for this program to keep running. So as Madam already said, this is a very good, interesting case where obviously the diagnosis seems to be straightforward, but the learning pearls or the learning points are many. So HIV with generalized lymphadenopathy is something which all of us will keep on encountering as many times as we see as we sit in our OPDs, because lymphadenopathy is something which is there right from the very early stages, the seroconversion stage, till probably even the advanced HIV or till full-blown AIDS. So lymphadenopathy, of course, after we are done with the case, we need to answer 3 questions. So whenever we see such a patient of HIV with generalized lymphadenopathy, and it happens to be whether it is because of only HIV, whether it is because of an HIV-related disease, or whether it is because of something which is absolutely unrelated to HIV. So these are the 3 questions which we need to answer whenever we see a patient of HIV with generalized lymphadenopathy. So I'll take you through my presentation, and I hope that some points get more clearer and more lucid. Thank you. So as the case was summarized, I would again iterate that ATT was very promptly started within 3 days of confirmation of the diagnosis. ART, the patient got registered thereafter, and ART was again very promptly initiated on 11th, which is around 10 days from the time of initiating ATT. On the background, we see a patient who is a 37-year-old person who does not have an active caretaker. His wife had died a couple of years back. There was no active social support. He was an alcoholic and a smoker. And as we can see from the weight which he has, a 37-year-old adult with a weight of only 45 kgs. So though I cannot comment exactly on the BMI of the patient, but yes, he appears to be grossly on the lower side of the BMI. The point which I wanted to make by presenting this slide was that confirmation of TB, of course, was done wonderfully well, and they went out and performed all the required investigations, right from CBNAT to doing all imaging studies, and to the extent of going ahead with a lymph node biopsy, which was extremely essential to ruling out a malignancy, because our first prerogative whenever we see a patient with generalized lymphadenopathy is to rule out malignancy, especially in a young patient with a good CD4 count. The non-HIV, non-AIDS defining malignancies like Hodgkin's lymphoma, they need to be ruled out, and they did it well. All that was required was done to prove that it was tuberculosis. ART was initiated pretty early, but yes, I do understand that within 2 weeks you can start for those who have a CD4 count of more than 50, but we have to make sure that the patient profile and his adherence, his toxicity profile, and if he is on, on the other side where he's on little more prone to develop complications of therapy, that also has to be taken into mind. Then comes his clinical presentation, which was having all constitutional symptoms, cough and dyspnea. Examination showed lymph nodes, both cervical, inguinal, and hepatosplenomegaly on clinical examination. The chest X-ray was suggestive of TB, ultrasound neck was suggestive of tuberculosis, and the CT scans were also suggestive of both lymph node as well as parenchymal tuberculosis. FNA was done and a biopsy was done. It was suggestive of a granulomatous lymphadenitis, and CBNAT was positive for Mycobacterium tuberculosis, and rifampicin resistance was ruled out. So this is the case of a 37-year-old guy who probably was already diagnosed with HIV, but was not carrying a HIV report when they presented to the center, was diagnosed with TB, promptly started on both TB as well as ART, and was thoroughly investigated. Now, the points which they had put up for discussion was, one is 99 dots patient. What could be an additional line of treatment for this patient, and the differential diagnosis of lymphoma, whether to be considered even at this point of time. But they have already probably answered the third question, but we'll still take it up. So is 99 dots 4 FDC enough for this patient? So the 2017 guidelines, the index guidelines, they do recommend that yes, a 6-month ATT, the standard first-line regimen, not just for peripheral lymph nodes, but also if your patient is presenting with abdominal lymph nodes, as in this case also, he shows retroperitoneal and mesenteric lymphadenopathy also. So a 6-month ATT standard first-line regimen is what is recommended for lymph node tuberculosis also. So you were right in giving a 4 FDC 3 pill as per his weight. So this is what was exactly required, and there was no, the CVNAT also showed that there was no rifampicin resistance. Also, what could have been done other than doing a CVNAT on the sputum, which of course was positive, and so there, it was not much of doubt that we're dealing with a case of tuberculosis, but the material, the aspirate from the FNA, can also be put to expert MTB for an additional, it's an additional test, and it can complement both microscopy, culture and cytology in FNAC specimens. So this is also recommended that smear can also, that aspirate can be subjected to a gene expert testing also. Now, what duration? That is the usual question. All of us keep on facing these questions, okay, that the tuberculosis, the lymph nodes are not regressing in size. They have either, you know, enlarged, and the patient is saying that he is not improving by way of decrease in size of lymph nodes. What should we do? Should we keep on increasing the duration of treatment? So that is another question which normally comes to our mind. Like at the end of 4th month, 5th month, the patient is coming to you saying that the lymph node size has not regressed. What am I supposed to do? And many of us are compelled to keep on adding on to our continuation phase of ATT. So yes, in certain times you can extend it by 3 to 6 months, but usually not in a case of a peripheral lymph node tuberculosis purely. But yes, when it comes to CNS tuberculosis, or musculoskeletal tuberculosis, yes, the duration of treatment is can be extended. This continuation phase can be extended. This is also largely a case of both pulmonary tuberculosis as well as extrapulmonary tuberculosis. So if required, based on clinical decision, it can be extended in certain cases. But extension beyond 3 months is usually not purely on the recommendation of the treating physician, but we should be taking a second opinion if we wish to increase it beyond 3 months. So it is important that we keep on assessing our patient, not just for the size of the lymph nodes, but we need to see the resolution of the constitutional symptoms also. So both clinical monitoring, lab monitoring, as well as histopathological monitoring might be required in certain cases where you might contemplate whether the patient has to go ahead with an extended continuation phase or not. So basically, this response to therapy is something which is a little problematic with tubercular lymphadenitis. It is characteristically slow to respond. So many patients would turn up to you saying that the lymph node has not shrunken in size. So ATT may actually even lead to an enlargement or presence of additional lymph nodes than what were there previously during or after cessation of treatment. But that does not mean, this paradoxical reaction does not mean that this is that tuberculosis is not getting treated, or this is treatment failure or resistance. This necessarily does not mean so. So most paradoxical reactions, as we say iris, this is also a paradox, can occur after initiation of ART. So a paradox can occur even after initiation of ATT. So not just for our HIV positive patients, even for our patients who are not HIV positive and are present with tubercular lymphadenopathy, we can have these paradoxical reactions. So they can occur between 3 weeks to 4 months of initiation of treatment, and cultures are usually negative in such cases. So you can go ahead with a repeat FNA if required, if the patient is constitutionally also worsening. And such reactions usually do not indicate a treatment failure. So this is just an exaggerated immune response to the dying Mycobacterium tuberculosis organism. And after initiating therapy, any one of these lymph nodes might get enlarged. They might show fluctuation. They may even show some spontaneous discharge also. So overlying erythema may also be observed. So all such can actually happen. So you have to keep your mind open that not necessarily after initiation of ATT, every case is not going to show regression of the size of the lymph node. So we are not exactly always concerned about the size of the lymph node, but yes, your patient is definitely worried about the non-regressal of the lymph node. Even in the chest, there could be a paradoxical enlargement, and you may find that your patient is worsening a little, right? Because it can cause even atelectasis at times. Constitutional symptoms by and large would not be present, because if there is presence of constitutional symptoms, your patient continues to run fever, he continues to lose weight, has decreased appetite, then and simultaneously you find that the lymph nodes are also not showing a response, you definitely need to revisit your diagnosis. Once diagnosed as TB, not necessarily that we have to continue with the same regimen, and or we cannot have an alternative diagnosis simultaneously also. So HIV paradoxical reactions like iris would be more common after initiation of ART, and this differential diagnosis of iris, I'll not really go into a deeper detail for shortage of time, but the differential diagnosis, you have to rule out whether there is non-compliance to treatment, whether there is treatment resistance, another infection, superadded infection, or an alternative diagnosis which is leading to such a manifestation. Basically, there's no consensus guideline for management of paradoxical reactions. At times, it's purely only observation and reassurance. Other times, you may require to aspirate, surgically excise, and you might be required to give corticosteroids and non-steroidal anti-inflammatory agents also. So it is important that if you have to see whether it's a paradoxical reaction or treatment failure, we need to go ahead with an FNA for AFP microscopy and culture again. So TB iris is something which is very common amongst all iris that we see, and it ranges from 4% to even up to 54% in certain studies. Risk factors, other than that, that the CD4 counts are below 100 at the start, which in our patient, of course, were pretty good CD4 counts, almost like close to normal CD4 counts of 498. People who have a rapid initial fall in their HIV viral load, unfortunately, we do not have a viral load. We could not repeat one. The patient never lived long enough to have another CD4 or to get a viral load done. That is another point as to what did he succumb to, which we are not aware of. And the patient died pretty soon, even before completing his full course of ATT probably. From the white card, it seems that the patient did not turn up for follow-up, and so we do not have an insight as to whether he continued with his drugs or what later happened to this patient. That is not known to us. Especially the severity of TB disease, I've marked it in red because this is what was present in our patient also. The high pathogen burden and the short time between initiation of ATT and ART. This is what was present in our patient. Male sex and relatively younger age. These are also certain risk factors for development of iris. Genetic susceptibility and high HIV RNA at ART initiation, both of which we could really not do anything about. So I would again like to make a point which I know that the program, it pushes us to do a quick ART initiation, but please take it on a case-to-case basis, especially when you have already initiated ATT first. In a patient who is alcoholic, does not have a care support system, does not have an active caretaker, who has been a defaulter previously also, you are already starting him on ATT, which is something relatively difficult to handle. His alcoholic status, his altered AG ratio as seen, of course his LFT was fine, but I would again reiterate that ART initiation is not an emergency. We can assess our patient from patient to patient basis. So optimal timing as given in literature, as given through our national program, that if the CD4 count is less than 50, you should start ART as early as possible or as soon as the treatment is tolerated, right? Except in cases of TB meningitis, where it has been found not to confer any survival benefit, and it's actually associated with some more severe adverse events within the CNS. So that is one of the exceptions. If CD4 count is more than 50, as seen in our patient is somehow very well preserved despite such disseminated tuberculosis, pulmonary tuberculosis. He still has a CD4 count of 498. He appears to be pretty malnourished given his weight. But yes, he does have a good CD4, fortunately. So CD4, if more than 50, we had almost 5 times that CD4. ART should be initiated again as early, but can be deferred up to 8 weeks also, especially if you feel that there is a possibility of drug interactions, there is a difficulty with adherence, there could be an increased chance of toxicity. So in such a patient, if given a choice, I would take a little more time to initiate ART than what we did. So, and a 15-15 day early initiation is essential, but a 15-15 day follow-up for such patients is also very essential. So though we do dispense 1 month the medicines so that the patient is not inconvenienced, does not have a breach of treatment early enough, but yes, we can keep on contacting such patients and put them in our high priority list so that the counselors can be more regular in contacting such a patient who is actually at very high risk for poor adherence and toxicity. And the second query, not just a query, just a statement, what could have been an additional line of treatment? So other than ATT, you have already initiated CPT rightly. Pyridoxine, yes, you started a 40 milligram, which is the usual available dose with us. Beyond that, what is essential is our care support system, not just medicines, but our care support system. An identification of a caregiver or someone, an NGO who can, be in regular touch with the patient right through his early days of ART initiation, adherence counseling about adverse effects, and the importance of a regular follow-up. That also has to be stressed upon. And these are the patients who do not have a regular family with them, people with them, and who have already been, who has tried to, not to disclose his HIV positive status to anybody till now. These are the patients who require more of counseling and more of support from the center. Alcohol abstinence, whether it's possible at that point of time or not, or whether the patient needs to be motivated enough, put to a center again, that is also to be taken care. Clinical monitoring is extremely important. It's not just doing a lab monitoring that, yes, my patient has good CD4, but yes, we did lose our patient despite that very good CD4, despite making a good diagnosis of tuberculosis. Something happened wrong somewhere. We do not really know what he succumbed to. If it was not because of disease, yes, we couldn't have done much about it. But yes, if it was because of the disease, there is something which is lacking in our follow-up and in the way we are trying to connect to the patient after initiating ART. Lab support is extremely important again because ATT-induced hepatitis and other issues can crop up in between. The patient might be, dissuaded severely from continuing both ATT as well as ART in early days of ART and ATT initiation. Nutrition support, another thing which is extremely important, both in patients receiving ART as well as in patients on ATT, that also has to be taken care of. And psychosocial support, at least in this patient, was important because he was single, he was a defaulter, he was alcoholic, and financial benefit, of course, must be extended to all patients, and all of us are trying to do it as well as possible. The differential diagnosis of lymphoma, should we consider it or should we not? So let me just tell you a little, what are the similarities between TB, lymphadenopathy and lymphoma, and why, as you have rightly tried to rule out lymphoma, why should we consider lymphoma in a young patient presenting with generalized lymphadenopathy? So classically, TB lymphadenopathy is also multiple, matted, hard to fluctuate, can have draining sinuses. In early stages, even like lymphoma lymph nodes, lymphoma lymph nodes are more rubbery, more discrete and firm. But in early stages of tuberculosis also, you can have similar clinical examination of lymph nodes of your patients. So commonly involved lymph nodes are again the same both in TB as well as in lymphoma. Both can have constitutional symptoms or just a non-specific presentation, as in our patient also. There was fatigue, low-grade fever, night sweats, weight loss. So not necessarily every lymphomatous patient also would have high spiking Pelebstein kind of fever. FNA, both show, unfortunately, granulomatous inflammation. So granulomatous inflammation can mask a lymphoma. So it is important that we go ahead to perform a biopsy as was rightly done by the center. So these are the similarities which can lead to a misdiagnosis of taking a lymphoma to be a TB lymphadenopathy. And we need to rule out malignancies and all other potentially treatable causes as well. Now, what are the clues, clinical clues, which we can see, or lab clues, which point to a non-TB etiology? So not very pertinent for all patients of HIV. This is in general. So age more than 40 to 50 years. Supraclavicular lymphadenopathy, sir rightly said that they had performed a good clinical examination and they've already undergone a USG neck as well as a complete CT also. So supraclavicular lymphadenopathy in isolation may point towards a malignancy. They do not have a history of exposure to a case of TB, but in India, of course, this does not really hold very pertinent. Most of the patients do have some or the other source, even if not a very close contact. An inconclusive repeat FNAC, if you've already done an FNAC twice and you still do not have a clue that it is purely a tubercular lesion. A normal TST, but again in an HIV patient, TSTs, because of skin energy, we are not going to have a positive tuberculin skin test. And lack of resolution, this is extremely important even once you have diagnosed. If you find that there is a lack of resolution of clinical symptoms or regression after start of ATT, we again need to make an effort to revisit our diagnosis or to rule out resistance or treatment failure. And the last point is presence of extranodal involvement. Other than lymph nodes, if other systems are also involved, the GI tract is involved, the CNS is involved, then we also need to again think about whether we are missing out on a diagnosis of lymphoma. Another investigation which I saw and which was good enough was that someone had really requested for an LDH also. LDH was close to normal. So LDH usually can be seen pretty elevated in cases of lymphoma. So as ma'am said, there could be n number of causes, and we have to remember patients of HIV do not come from another planet. They are equally susceptible to causes of lymphadenopathy, which the general population has. Plus, they are at higher risk for certain HIV-related diseases, which puts them at higher risk of having those causes of lymphadenopathy also. And then, of course, persistent generalized lymphadenopathy, where the cause is only a reactive hyperplasia secondary to HIV. So this is the differential. I would not really read through each of them because probably I'm already ahead of my time. So the most likely alternative diagnosis would depend on the clinical setting, the age of the patient, the immune status of the patient, and the presenting clinical features. So a very thorough clinical history, general physical examination, systemic examination, and lab investigations, they are required. And not just these causes. If you look at the causes of lymphadenopathy, generalized lymphadenopathy, they are many, many, many more than what I have listed. So persistent generalized lymphadenopathy, it can be seen very early in the course. And it is when there is presence of lymphadenopathy for more than 3 months and the palpable lymph nodes are there more than 1 centimeter in 2 or more non-contiguous areas. So lymphoid hyperplasia is the most common cause. That is a WHO clinical stage 1 illness. And mostly PGL has more of head and neck lymph nodes which are involved. But yes, as the name suggests, it can be any of the sites or almost all of the sites. So in our country, it is mainly the infection which we have to keep seeking is tuberculosis. In non-endemic countries, it can be non-tubercular mycobacteria like MAC. So tuberculosis lymphadenopathy, it is the most frequent presentation of extrapulmonary TB. And extrapulmonary TB is seen in almost 40 to 45% of patients of HIV. So either it could be reactivation or it could be a miliary dissemination. So in endemic regions, yes, as in our country, as I said, we can even see extrapulmonary TB to be accounting for 60%. And the most common presentation, of course, is lymphadenopathy. So you're going to see these cases daily in and out. So obviously what would be the clinical presentation like. Some uncommon findings could also be there. There could be a draining sinus. You can have skin changes. Erythema nodosum can also be seen. You can have fluctuations. Abscesses also present. So these could be the uncommon findings other than what we normally see in a case of lymphadenopathy. FNA, of course, it is appropriate for initial evaluation, safe and inexpensive. Yield is fine. And you can have an endoscopic ultrasound-based also. The TBNA can be done to provide access to intrathoracic lymph nodes also. Excisional biopsy, as you rightly did, it has the highest diagnostic yield, and you prefer it over incisional biopsies for because you want the entire lymph node architecture to be preserved. Plus, you have that issue of formation of sinuses following an incision biopsy. Imaging, chest imaging, X-rays, pulmonary involvement can be seen in HIV patients. Up to 90% of patients will have involvement seen in the chest X-rays also. And ultrasonography is also a good tool to see for central necrosis also in certain patients. You can see it well. CT and of course PET-CT has also been used, but yes, PET-CT does not really help out much in differentiating exactly between a lymphoma and a TB lymphadenopathy. So again, my take-home message from this case would be, of course, all of us know it is the most common OI. We have to understand that per se, if it is only HIV which is causing lymphadenopathy, whether it is another disease which is attributing lymphadenopathy to just because the patient has HIV and is at increased risk for such diseases, or it is an entirely non-HIV related disease present in an HIV patient. So that also has to be kept in mind, because the entire list of lymphadenopathy is applicable to all patients of HIV also, as much as they're applicable to HIV uninfected patients. So there are multiple mimics. Gene export is something which is really to our rescue, and it is quick, and most of the centers now have access to it, and we can use it to our advantage, even in patients of lymphadenopathy also. And early treatment with ATT, of course, is very essential. Timely ART is again essential. Paradoxical iris, all of you, I would like to say, is to be kept in mind, and try and see it on a case-to-case basis. And of course, nothing beats a comprehensive medical management care and support, which is mandatory for not just patients of HIV and TB, but for all of our patients of HIV. Big thank you to all of you. And I'm not sure if I'm supposed to take questions at this point of time, if at all.
We'll just ask them, ma'am. Thank you very much. That was, I think, one of the most excellent talks that we've had on the session. It was crystal clear, as I understand. And I don't think there's much to summarize, except I will do my duty of summarizing. But before I go on to summarizing, would anybody want to ask Madam anything before I do the summary? Ma'am, there's a question from NRI ART.
Sure, ma'am.
Good evening, madam.
Good evening, sir.
Thank you for your briefing about HIV association with the TB. I'm Dr. Murali Venkateswara, Professor HOD of General Medicine. Thank you for briefing and suggesting us to follow the cases with HIV TB. And what it is in our case, the earlier before coming to ourselves in AIMS or other hospitals, they started ATT earlier or ART by simultaneously. We don't know if it was there simultaneously treated. It is the anti-HIV treatment. ART treatment can lead to this immune upregulation, leading to hyperplastic hypertrophy of the lymphadenopathy and disseminated as early without other soft tissue structures involvement like that CNS or meningitis or tuberculoma like that. Is it possible there?
It is possible, sir, if I get your question right. It is a possibility that, yes, the patient did have TB lymphadenopathy, disseminated tuberculosis, and inadvertently we added on to it just because we do not have the previous baseline CD4 for the patient when he was actually diagnosed with the HIV and was started with ART. And maybe this CD4 which we saw at your center, the CD4 of 498, might have been one of the CD4s post ART, and maybe we were into a phase of iris. We could have figured that out only after performing. If we had a baseline CD4, that would have been one of the ways, because if the CD4 is improving and yet your patient is clinically deteriorating or the lymph nodes are getting bigger in size, then of course we can suspect iris. So of course this could have been up there. This is a possibility. But even if I'm not sure what kind of ART was the patient taking previously, but if the patient was already on it for some weeks, then there is a fair chance that this was a patient of TB iris.
Yes, take a TLE, madam.
Okay.
TLE.
So that doesn't really make a huge difference whether it was put on TLE or TLD. Whatever was available was good enough. Either TLE or TLD was good enough. But somehow I thought that it was TLD as per the card given. So what he was receiving previously, again, doesn't really mean that somehow he still has, even if it was iris, the CD4 is pretty good, even it was iris. So what led to death was something which is very intriguing me, and unfortunately, we do not have an answer to that. What finally claimed his life, that we do not have access to that information. So that is one thing which I was very, very, intrigued about, and I wanted to know. Was it the disease per se? Was it this iris? Because even iris normally would be self-limiting, but can get life-threatening also. So these are a couple of questions which I'm left with, and probably there are no answers to. Thank you so much.
Thank you, madam. That's why I'm everybody to know, no hurry to start as early.
No hurry to start ART. Look, the national program, of course, has its own issues. It will always tell you to start ART because that is definitely the priority. But starting ART in a patient of ATT, you should be thinking twice. And in a patient who is an alcoholic without a good support system, he has been a regular defaulter previously also, we have to be pretty sure that at least minimum with a CD4 of 498, which is pretty good for us as of now. We can, in earlier times, we never used to start an ERT even till 250 CD4. So in such a patient, we should be taking a little more time. Let's see how he, gets used to his ATT first. Once he is good enough, has accepted his ATT well, maybe it might take 4 weeks, 8 weeks. Then, of course, we can go ahead with starting ART. So all those goals are not to be followed in all patients to the dot. But with patients of TB, we have to be very cautious.
Madam, actually, previously, as the nodal assessors at the time, the Gujarati model had all the tuberculosis doctors and other things they suggested at the same day you have started. Why you have not started like that? They fight. But at the time, we are the senior officer subjected for that because of the importance of the TB treatment, because otherwise they develop meningitis and other complications. So, ART may be given a little later. So, at the time, a lot of discussion was there. Madras Chest Hospital professors and others, Rajshekar and others suggested. Then after taking what are the conclusions, finally they agreed 2 weeks to after 2 weeks to 2 months. In the between, this critical vision is important. But the latest guidelines of 2021, in that this is mentioned that we have to start before 2 weeks.
So one more thing, madam, what is the important factor? Once we started ATT, how the patient is responding, improving, symptomatic relief, and improving laboratory, we can start with that monitoring as early ART.
Especially, sir, when the gastrointestinal symptoms and the LFTs. So in clinical monitoring, if your patient is not vomiting, is accepting, is still orally accepting his meals well, there would be majority of your patients who will not be accepting ATT in the initial couple of weeks. You will be forced to give them PPIs and other things, which are again having a little, not with the routine TLD, but yes, if your patient is on atazanavir, etc., you're not supposed to even give those medications. So the pill burden suddenly was very high in initial phases of starting ATT. And it's very difficult to convince a patient that despite you having GI symptoms, you still have to go ahead and keep on taking your ATT. If and then to, clinically as well as lab wise, you have to see your patients for hepatitis also, ATT-induced hepatitis. If all of that is settled, which usually by 4 weeks, 6 weeks, we get to know whether the patient is accepting your medicines well or not, we can go ahead with initiating ART also. But this patient was malnourished.
Please can I comment in the interest of time? I'm so sorry, I'm interrupting everybody's discussion. So with that thought, I would still like to reiterate that 10 days starting ART after 10 days of ATT was not a very small duration. I think in the case of disseminated TB, even if the CD4 is 498, I would still go ahead with the thought that I think it was a good call by your team to start it about 10 to 12 days later, because in 10 days, I think you must have been able to observe whether the patient was vomiting due to ATT or not, and whether he was taking it orally. And in addition to whatever Dr. Raizada has said, I would still suggest that we should err on the early side. We should not err on the late side when it comes to co-administration of ART. Once your patient has stopped vomiting or his GI symptoms have settled, if they are not settled, then please try to get them settled. like you give them probably some antiemetic, and PPIs we usually avoid because they have a because they sort of like have a drug interaction with rifampicin. But yes, as madam said, at times you have to give them. They do not respond to Rantac. We know they have drug interactions with rifampicin. Still we have to give, and then when we have to choose, we usually choose Rabli, because rabiprazole has the least drug interactions with rifampicin. So if you are not able to settle your patient in the first 2, 3, 4 days of ATT, every effort should be made that by the end of 7th, 8th, 9th, 10th day. Why I am saying this is, we are a TB hospital, and in our hospital practically everybody is on ATT. Everybody is on ATT, and we have to settle them. If we don't settle them for the 10th day onwards, then actually TB treatment also gets compromised and patients die very rapidly. Patients of TB die very rapidly if we are not able to adjust them to their ATT. And agreeing with everything that Dr. Raizada has said, as a recommendation for the field, it would be to see if your patient is not vomiting, he's tolerating, then I would suggest that we should go ahead with ART as soon as possible, because ART would take a certain amount of time to start kicking in. And in the case of so much of disseminated TB, we need all our weapons that we can provide to the patient. But somehow in this patient, it turned out to be counterproductive. The thought process was correct, but clinical history told us that what we probably, if we had delayed it, as Dr. Raizada is suggesting, that might have been a better option for this particular patient. But then we need to understand that we should have that discernment, that ability to discern in us. Like we should be able to say who to give, who not to give. Voilà. So if in any doubt, I would request the ART medical officers to go ahead and please touch base with their nodal officers if they have a doubt. Don't take a call on your level, whether I will give it later or whether I will give it earlier. Okay. So if you want to do, standard is the guideline. If you want to deviate from the guideline, consult your nodal officer. Madam is a nodal officer, and it is her prerogative and her clinical experience that she can take a call. Okay, guidelines is guidelines, they guide you, but they are not orders or laws. Okay, so yes, what ma'am says is absolutely correct. The other thing I wanted to ask was, when did the patient pass out, sir? When did the patient expire?
2 months, madam. 3 months.
2 months after treatment.
We followed him. He is not available. He went to some other native place where I am taking test, he told. But after coming back, he is very good, very good stage. But his father says, but only thing is not taking the medicine regularly. Go on drinking. Some functions are there. So he drank more.
Yeah, active alcoholism on the background of disseminated TB and HIV, which was, patient was obviously sick. If we consider the lab report of 498 to be absolutely correct, then the patient was in any way clinically sick, and then active alcoholism might have contributed. As madam said, we will never be able to find out. And just in the interest of time, I will not summarize because our presentation was crystal clear. Only thing in lymphadenopathy, what you have to understand, what you have to think of, PGL, as ma'am said, PGL is more than one lymph node site, and it should not be a contiguous site. What is a contiguous site? Like for, if you have a supraclavicular lymph node, what is the contiguous site for it? The mesenteric lymph nodes. Okay. So for supraclavicular, it will be the mesenteric lymph nodes. So similarly, you have to see if there is, the involvement is disseminated or diffuse, like the contiguous sites of lymph nodes are not involved, they are more than 1 centimeter and persistent for more than 3 months, then it would be persistent. It would be PGL. Yes. TB is commonest in this country. Always round up the most usual suspect first. Okay. Think of usual things first. Second would be MAC, but at this CD4 count, obviously nobody would think of MAC. Third would obviously be lymphoma. And also the fifth that we have to think of really seriously in HIV is disseminated fungal infection. But then again, we would expect a lower CD4 count for toxo, for fungus, for MAC, and lymphoma you ruled out. So it came down to disseminated TB, and most likely the patient expired due to his active alcoholism and not taking drugs. So would anybody like to add anything to it? While I would request her to pull up the post poll.
The post-test polls are on your screen. There are 2 questions. Kindly respond to them.
Ma'am, would you like to add anything to this, Dr. Alpana?
No, ma'am, thank you. You've summarized it pretty well. And yes, that is the only statement, again, from my side, that please take it on a case-to-case basis and with good consultation from someone with more of experience in dealing with both the HIV as well as tuberculosis before we either initiate or postpone ART.
Yeah, excellent, excellent. I think again and again, the message that we are sending here is that, like Dr. Dharmapal's team did, they did a group discussion, they did a ART team discussion. That is, I think, one of the excellent things that we can take back from this talk, that whenever in doubt, please consult somebody with the requisite expertise. For example, this case particularly, we could have probably a delayed ART might have been better, or a more stringent follow-up might have been better. Maybe he was one of those guys who needed an NGO link-up. So always do a team meeting. Yeah, and do we know what is extrapulmonary TB? What is which WHO clinical stage is extrapulmonary TB? What WHO? So this case was of extrapulmonary TB.
Yes, it is. But the classification is whenever there is any signs or anything found in lungs, even though lymph node other sites are there, we have to put it in only pulmonary TB. They told.
Yeah, we have to put them as pulmonary TB. That classification is of the TB program.
Yeah.
You have to understand that under RNT-CP or under NTEP, if a patient has pulmonary and extrapulmonary both, they classify the patient as pulmonary TB because monitoring of the patient by sputum is any day easier than monitoring the patient by extrapulmonary samples. So if you look at the program point of view of NTEP, they label the patient as pulmonary TB. But when we talk, but just a minute, sir. But in the HIV program, when we talk of extrapulmonary TB, except if it is an isolated cervical lymph node, Dr. Raizada had also said that, except if it is a cervical, isolated cervical lymph node, it is a higher stage of HIV disease. So when we have disseminated extrapulmonary TB alongside pulmonary TB, when it comes for WHO classification, I am not talking about the NTEP classification of TB disease. I am talking about the WHO classification of HIV disease. So once you have extrapulmonary, which is a higher, we all in WHO classification always remember the stage goes to the higher problem. You can have oral candidiasis and you can have meningitis. Okay. So it will not be stage 3, it will be stage 4 because of meningitis. Similarly, in HIV, you can have pulmonary TB, but if you have disseminated extrapulmonary TB, it goes to the higher stage. Is that clear? Should I repeat myself? Ma'am, would you like to add anything?
No, ma'am, just that other than do not take lymph node TB, the peripheral lymph node, isolated peripheral lymph node TB to be a disseminated TB as such. So if it's only peripheral lymph node isolated, then it goes to class 3. And extrapulmonary TB of all other forms would go to a WHO clinical class 4. So lymph node TB is isolated cervical lymph node TB would be lymph node TB would be class 3 for adults, WHO class 3 for adults. Rest all other forms of extrapulmonary TB would all be for class 4 when you classify them.
But this only applies to isolated cervical. Only cervical, isolated cervical lymph node. Like if you have a single lymph node in the mediastinum, or if you have a single axillary lymph node which is AFB positive, it would still be classified as extrapulmonary. Request Anuradha to kindly give answers to the post-test.
Yes, the answers to the post-test are really very clear after the summary. The first question was a PLHIV with peripheral lymph node tuberculosis will be classified into which of the following? The correct answer being WHO clinical stage 3. Now the second question was an ART naive PLHIV is initiated on rifampicin based ATT As per national program, first line ART for the patient will be very clearly the D choice, TLD plus D. So these are the correct answers for the pre and post test, and most of you have done very correctly the post that evidently shows the brilliant session taken by Raizada ma'am. Thank you so much.
Thank you so much, Dr. Dharmapal. Have you got the answers to your questions? Is it okay, sir? Can we close the session now? Ma'am, do you want to say something else, or can we close the session now?
I'm fine with closing the session. Thank you so much for having me here.
Thank you very much.